I'm Dr. Bianca Levy. I am a supervising psychologist at the Gordon Therapy Group, and I'm here with my colleague, Dr. Daniel Schlussel, to talk about selective mutism. So first of all, what is selective mutism? Selective mutism is a type of anxiety disorder in which an individual consistently fails to speak in specific social situations where there is an expectation for speaking, despite speaking normally in other situations. So for example, a child with selective mutism might fail to speak to teachers or classmates at school, but have no difficulty speaking with parents and siblings at home. Estimates of the prevalence of selective mutism range from 0.3 to 2%. That might seem low, but to put that into perspective, the prevalence of autism spectrum disorder is about 1.7%. In almost all cases, children with a selective mutism diagnosis are also diagnosed with another anxiety disorder, most commonly social phobia, separation anxiety disorder, or specific phobia. Symptoms of selective mutism often present between the ages of 3 and 5 years, although a diagnosis is often delayed until elementary school, where the absence of speech is more noticeable. Selective mutism may persist for months or even years and may result in social impairment, as children with the disorder may be too anxious to engage in reciprocal interaction with their peers and become isolated. Furthermore, left untreated, selective mutism frequently leads to academic impairments because children cannot effectively communicate their needs to their teachers. It's highly recommended to seek intervention as soon as possible because even though symptoms of selective mutism may disappear on their own in some cases, very often symptoms of social anxiety disorder remain and can even persist into adulthood.
Selective mutism is often confusing for parents because they see their child as talkative and bubbly at home, and then they're kind of shocked when a teacher reports that they haven't even said anything in class. Sometimes the effects can be limited to a child's interaction with certain individuals, like a specific teacher, or to certain spaces, like the school building itself. And it can be really easy to misinterpret the signs of selective mutism. Parents often describe their children as shy. Some parents might even think that their child's being kind of oppositional, that they're refusing to talk. They're capable of doing this in other situations. Why are they refusing to do it here? But selective mutism is different from typical shyness. Shy children generally warm up in new situations, and then they're able to keep moving as developmentally appropriate. And unlike those who are shy, kids with selective mutism, even once they've warmed up, are unable to speak, and they become uncomfortable even after they've become comfortable in settings. So a child with selective mutism might be able to happily run around with peers on the playground, but they can't necessarily speak with them.
In addition to clinical observations and interactions with the child, psychologists also want to gather information from multiple informants in different settings with regard to the frequency and the severity of a child's mutism. There are questionnaires that could facilitate this process as well. And psychologists would assess then the academic and social impairment that result from the child's failure to speak. They would also ask about and weigh any previous attempts to intervene and resolve the symptoms. So many psychologists might develop a goal ladder in collaboration with the child and their parents. This ladder would provide the child with a visual hierarchy of goals to which they can refer as they progress. A typical first rung goal for a child with severe selective mutism might be to communicate nonverbally, for instance, by using pictograms or gestures. The next rung up might be nodding yes or no to questions. The next rung up might be just mouthing words, and then whispering would be a rung above that. Vocalizing maybe a word or two, maybe to someone they trust or someone they feel more comfortable with, and so on and so forth, until the child is able to speak with a regular voice in all settings.
Another key component of treatment is parent and teacher trainings. So parents and teachers have the greatest influence over a child's daily environment. And so by changing how these caregivers respond to the child's anxiety, we can directly influence how a child learns to handle difficult situations. So therapy often focuses on teaching caregivers unique skills to help grow children's comfort and confidence in certain situations, to reduce avoidance cycles, to target these verbal exposures that Dr. Levy mentioned. One of the most effective forms of treatment is called parent-child interaction therapy adapted for selective mutism, so PCITSM, which combines the caregiver training with the behavior therapy exposures. Sometimes it is also important to have other school-based interventions, such as 504 accommodation plans, temporarily reducing demands on a child in a classroom setting for at least oral responses, so that we're not forcing the child to speak to a person whom they're not yet comfortable with before they've made it to that point on the ladder.
I would say a lot of working with anxiety disorders and children is making it seem less pressureful and more game-like and fun. So oftentimes, even as we described, like the different rungs on a ladder, what we're actually doing in practice is obviously tailored to the child and what they like, and also paired with rewards, so that the whole experience actually feels less anxiety provoking and more fun, while they are habituating to doing things that they haven't been comfortable doing in certain settings.